Okay, so next, so you'll have some introduction, go through some basics of pain pathways and see how we utilize opioids and look at an interesting case study, see how we would have dealt with it. Next, Paul. So we all know that pain is number one reason why patients will come to us, will go to pharmacies, will go to chemists to seek for medications, whether it is a prescription only medications or over the counter medications. If you talk to our colleague pharmacists or those who man pharmacies, they will tell you that the most commonly asked for drug is in a class of painkillers. However, literature shows that pain affects, especially chronic pain, it affects more than 20% of adults in the entire world, meaning about 1.5 billion people are in pain as we speak now. That's a huge part of the population. And interestingly is the fact that it remains undertreated, poorly understood, and the approaches are not as good as should be for such a common symptom affecting 20% of the adult population in the world. Next. So why do we have these? It's because one major reason is, do we understand the total concept of the pain, the concept of total pain? That on top of the physical aspects of pain, the pain also has got some socio-cultural elements. How is it viewed? How does the patient understand the pain that they suffer from? Is it accepted culturally? Or do we have to rush to go to doctors and seek for pain medication? Or do we have to go to the forest and look for some roots and apply on the diseased or paining part of the body? And do we accept it as part and parcel of living, as it were, at a certain age? Is back pain, for example, acceptable because we are at the age of 60, 70? Then there's the existential question of people who have chronic illnesses, life-limiting illnesses, suffering from pain. So there'll be existential, spiritual questions about pain. And of course, this is accompanied by the psychological, emotional question of why they are suffering from pain. Unless you pay attention to all those aspects, all these confounding factors of pain, you might not effectively and efficiently be able to manage the patient's pain, as it were. Next. And how do we look at it? Let's see chronic pain especially as suffering, not as a symptom. Pain is what the patient experiences, but when it extends beyond the patient, then it becomes like a syndrome. So there will be tissue damage by any disease, be it cancer, be it any other disease. And then the patient will, of course, have a pain sensation. Long-standing pain sensation bring in negative thoughts about why am I in pain, what is happening in my joints, what is happening in my pain, what is happening in my head. Could there be a swelling? There's so many questions we ask ourselves as human beings. Remember, we are rational and reasoning. So anything we go through will bring in thoughts about why is it happening. As it goes with emotions will come in. Withdrawal, patient being having negative ways of looking at things, including interrelationships. So as it extends or continues, of course, now it goes beyond the environment of the patient, and now it's called suffering. It affects those around the patient, the stakeholders, the next of kin, the workmates, the employer, the people the patient will deal with. And this now will lead us to saying that this person is always complaining of pain. So they have pain behavior. And now outside there in the environment, now all these factors, all these points, all these confounding factors become even worse. And the patient become withdrawn. They want to avoid us because we don't understand them. Today, I saw a patient who have suffered migraine for the longest time. Now, the problem with her is not actually the migraine itself, the pain she suffers from. When she has that pain, the problem now is going to work. And saying that I'm not today having a headache, and people wonder what really happened last night, that this person is not complaining of pain. So these factors have to be taken into consideration if you are to truly take care of a patient's pain. Next. And I believe it's good to come to this in respect to management of pain. There are two types of pain as far as management is concerned. There's that pain that will affect the organs. So if it is external organs, it could be somatic, internal organs, the so-called open hollow organs should be visceral pain. And any pain that affect any nerve, whether small nerve of the biggest nerves, is be called the neuropathic pain. And the commonest pains that we know that are neuropathic are postherpetic neuralgia, trigeminal neuralgia, and neuropathy brought about by poorly controlled diabetes. However, let's be very careful that it's rare to see a patient with chronic pain who only have nociceptive pain. And if we miss the neuropathic element of the pain, then we might not be able to truly manage the pain as well as we should. And we might find ourselves going higher and higher on some drugs while not having a reciprocal effect on the patient's experience of pain. Next. So how do we do this? We might not be able to go through these 7 points. You have to assess the pain multidimensionally, as we have mentioned, the 4 facets. Use the WHO leader for management of pain, what drugs fit who. It's not everybody who come to us who will go to prescribe Brufen or Panadol. Some will prescribe other stronger medication. Not everybody who come to us required to be on morphine. So what system do you use? And the commonest system is the WHO pain management letter. These people are in pain, and we usually recommend that we use oral drugs and let it be regular. TDS, QID, OD, BD is good when you indicate it in your notes as a clinician, in the electronic health record, in your written note. But when it go out there to a patient who is not a clinician, OD or BD or TDS means totally different things. People will say, I take it when I wake up, during lunchtime, and when I go to sleep. You meant 8 hourly if you say TDS. Then they understand they associate it with some activities. And most of the time, it's the social activity called feeding, because in between feeding or taking meals, some other constructive activities are happening. Now, between 2 regular doses of a strong opioid, we have to consider using breakthrough pain drugs and doses. And of course, because of neuropathic element, adjuvant drugs are used. Those are drugs which were manufactured not for pain management, but they have been shown to be effective. And of course, we have to use morphine and other strong opioids in management of pain. So then this is what will be our major discussion today. How do we use and utilize the strong opioids? But these 7 factors are very important for us to consider. If you go directly to talking about morphine without all the other elements, then you'll have some negative outcomes of utilization of opioid, whether weak or strong. Next. So what are the key points? The key point is to really understand the basics of the neurophysiology and the pathway of pain. There's pain production, there's pain transmission, there's pain perception, and there's modulation of pain. And modulation can be negative or positive. We would wish to have a negative modulation that brings in the experience of pain to the patient. It's important to know that no single drug will be taken to relieve given pain, especially in the chronic stage. And the key points that we need to consider, next, Paul, are the pathway itself. at the point of transduction or production of the pain stimuli, it will need to be transported. And if it's a toe that is paining, then this has to be transported all the way to the brain, because it's the brain that perceives that we are in pain. So the production is transduction, the transport of that given stimuli or electrical activity through the different nerve fibers, jumping from one to another using synapses, is the transmission. Then it goes to the brain, and we now know that we are in pain. My leg is in pain, my knee is in pain. Yes, you feel the pain in the knee, but the pain is perceived in the brain. But across these two, from the knee to the brain, there is some element, especially in the spinal cord, the dorsal horn, and the other pathways within the spinal cord where modulation can happen. It's also happened in the central nervous system. And modulation can say that let's now not perceive this pain as severe pain. Let's not perceive this as pain. And people who are used to pain, who has experienced the pain before, could have either a negative or a positive modulator. And that's why it is critical for us to educate the patients about pain and inquire whether they have experienced the pain before. And this pathway now tells us that the next step after understanding this is what we call pain assessment. And we have to essentially assess pain in all its main ways. What brings about the pain? What is the quality of the pain? Is it at one point, or does it radiate? Have you had this pain before? Similar pain. What have you used for that pain before? Are you using any medication right now? What do you think is causing this pain? What time does this pain occur? And given your pain, what level would you give it in a score? You can use a score of 0 to 10 or 0 to whatever, as long as you give pain visibility as far as figures are concerned. And also because of this, we ask the patient, what kind of pain is it? And let the patient use their own terms to explain their pain. It's numbing. I feel like electric shock. It's like cramping. It's like someone holding me with some patient will say with low back pain, say it's like those things you give us to put, but they are tight. They mean lumbar corset. Let them use their own terms. And because of utilization of those terms, you'll be able to classify this pain as both either neuropathic or nociceptive. But remember, please listen to the terms that the patient use. Next. So you give it visibility, and the commonest used tool for pain will be the numerical pain scale of 0 to 10. 0 being no pain and 10 being very severe pain. And you try the language that the patient understands. It's very easy to ask the question of 0 to 10 from patients in English. But I would want us to do an exercise when you go back home and ask that question in your own language, your local language, your community language, whatever language you use commonly with your friends. But whatever tool you use, whatever language you use, try to see whether it falls between 0, where there is no pain, and 10, which is the most severe pain. A word of caution from experience is that we all tend to aim for 0. But please inquire from the patient about what level of pain are they. And some patient will say, I have a pain at 2 out of 10, and that to me is acceptable. Will you still fight for this patient to have a pain score of 0? Our aim, yes, would be 0, but communicate with the patient continuously about what pain they have. You take care of patient with severe pain at 10, and when it gets to 3 or 2, they say, oh, the drugs are working. I cannot be able to work, I go to work and all that. Although the pain is there, it is distant, but it's acceptable. I can live with it. But this is a scale we use to show the numbers as far as pain is concerned. And that's why we have been saying that pain is the fifth vital sign. And if you look at international standardization and accreditation, there's insistence on the fact that pain must be assessed. In the clinical area, for example, the Joint Commission International expect that nurses will assess pain, doctors will also assess pain. And that's why it's critical for us to talk about this. Next. So as we use these tools, therefore, I know we are clinicians. I know we've gone through pathophysiology, we've gone through pharmacology, and then we tend to discuss about pain management, going all the way to starting drugs. Yes, this patient has got pain at 6 out of 10 or 7 out of 10, and then I rush to give molecule A or molecule B. That is one of the biggest failures that we make. Remember when we said about assessment, do multidimensional assessment, you might realize that there is more psychological, socio-cultural issues about pain. So we like starting at the point of patient education. As we said, ask all those questions from the patient, especially in the assessment and about the experience of pain. Then go to the other non-pharmacological pain management modalities, counseling. Do you have a puncture? Does the patient find some of the activities of daily living where they enjoy doing things or hobbies as something that can relieve their pain? Does exercise help? Massage therapy, relaxation, and all those other techniques that we can use, including art and music and traveling. And pet therapy is also coming in strongly. And people will tell you when I'm with my pet, when I walk with my pet on the ground, then I feel that my pain is well controlled. So before you talk about non-opioid or opioid, please always consider the non-pharmacological modalities of pain management. Next. Then now, as we continue, we say that we use the WHO pain management ladder. So we go to classification and we saw that 0 is no pain, 1 to 3 is mild, 4 to 6 is moderate, 7 to 10 is severe. So this is mild, and these are the drugs we use. You can use non-steroidals and acetaminophen molecules. If it is moderate, then you can use weak opioids. If it is severe, you use strong opioids. On using this WHO three-step ladder, remember there's a fourth step, which is the utilization of other interventions for pain management, including nerve blocks. But for the sake of today's discussion, let's look at these three levels. The weak opioids are common. Codeine, dihydrocodeine, DF-118 contains codeine. You have tramadol, you have tapentadol, you have betapin, which is also a combination, and there are so many others coming to the market. But we also have the strong opioids, which are available in many places. But because it is a stepwise ladder that we use, we don't essentially have to start every patient at level 1. It's at the presentation of the patient that we start them with the drugs. So we don't say that we did not try paracetamol, and then we go back, try paracetamol, then we go to codeine, then we go to morphine. It depends on when and how the patient present with whatever severity of pain. Remember, we looked at the scale of 0 to 10, and we said what drugs can be utilized. This table of these drugs is critical for us to look at it closely. And ask yourself, in your own hospital, among these three classes, what drugs don't you have? Do you have paracetamol? Maybe you have brufen, which is an non-steroidal. Maybe you have adjuvant medications. Do you have codeine? Do you have DF-118? Do you have morphine? And you realize that most institutions will have for most of these class, at least one drug in each and every of this class. But why are 20% of the adult population in the world not having pain relief? It's not like we don't have the drugs. The drugs might be there, although the accessibility and affordability might not be assured, but most of the medications could be available. Next. And this brings us now to the discussion about opioids. If you look at opioids, there are two types of opioids. There are exogenous opioids and there are endogenous opioids. The endogenous opioids are called endorphins. And we have a lot of opioids in our body and in our systems that controls or bind the receptors, the opioid receptors, so that anything we do, any movement that we have is not painful. And whatever we give, essentially from out there, the tramadol we give, the betapine we give, the codeine we give, the methadone we give, the morphine, the fentanyl, are external or exogenous opioids. So what they do is they mimic the natural morphine that we have or natural opioids that we have. The opioid that we have in our body is morphine itself. So, of note is the fact that what we give from external and whatever formulation we use is to supplement what we naturally have. And this is an important point for us to understand. If we are supplementing, then it means that we have ways of avoiding severe side effects or all the other negative outcomes that we are going to talk about: addiction, dependence, pseudo-addiction. So opioid can be naturally occurring, and the naturally occurring opioid is the endorphin that we have, but also morphine is the naturally occurring opioid. But they can also be fully or semi-synthetic. They bind to so many receptors, alpha, kappa, delta, and then as you realize from the WHO pain management letter, they can be used for either moderate to severe pain. They are not only used for severe pain. So you cannot get to the point of utilization of opioid before you assess it. You have to assess the pain for you to scale it or to score it, and then say it is either severe, moderate, or severe. And it's been shown to relieve somatic, physical, or neuropathic pain. Some of them do actually treat neuropathic pain. Next. So let's start with this drug called tramadol. Tramadol is a very common medication that we use. In Kenya, tramadol is still accepted as over-the-counter medication. And this is a danger because being an opioid agonist, it can be used for moderate to moderately severe pain. It's a weak opioid, yes, but it can be used for these levels of pain. Remember, tramadol can be on its own molecule or in a combination of other drugs. Most of the combinations we have is where tramadol itself, as a weak opioid, is combined with paracetamol. And there are many generics about the combination of tramadol and paracetamol. It's common, and we see it also parenterally, and it can be used parenterally, especially IV or IM. It's one of the opioids or weak opioids that do also treat neuropathic pain. So it will inhibit the reuptake of serotonin or epinephrine, and therefore reduce the sensitivity that brings about the sensation or the experience of neuropathy or neuropathic pain. However, tramadol itself have got some severe side effects. The commonest I've seen from practice is that it causes immediate nausea, vomiting to patients, especially when it is given intravenous or parenterally. It's also known to cause constipation, and constipation is one of the common side effects of most of the opioids, and it can cause dizziness and also a lot of sleepiness. It's therefore very important for us to make sure that as we recommend this drug, we also make sure that the patient meets the criteria of receiving tramadol. And if you are giving in combination, make sure that you assess the patient for their tolerance or ability for the body to take care of paracetamol as a combination with tramadol. So it's common, available over the counter, and we've seen most people will use it not as per the way it is prescribed, but as the way they would wish to use it. So you realize some people will use 2 tablets, 3 tablets, 6 tablets, but nobody prescribed. And when they go to the chemist or pharmacy, the pharmacists do sell the medications to them. That's very dangerous because people will become either tolerant to the drug or they can actually easily abuse the medication. And we can tell stories about tramadol for so many patients. Tramadol is in the same class as betapin. Betapin is a combination of codeine and paracetamol. And I don't know whether you remember in this country 4 years ago, betapin was made a prescription only medicine because everybody was buying betapin to treat their pain, whether low back pain or headache. But tramadol still remains an over-the-counter medication. So let's educate our people on utilizing these drugs without prescription. It's more dangerous because, as you know, it can bring issues about abuse, diversion, and all that. You can go to the next. Morphine now become the opioid, as we said, the naturally occurring opioid. All the others are either synthetic or semi-synthetic. So as the only naturally occurring opioid, it's become the opioid of reference. So you hear people saying, is it equianalgesic dose of morphine? Is it equal to a certain dose of morphine? Because the molecular derivatives or composition of morphine is similar to the endorphins that we have in our body. The metabolism of morphine itself is in the liver through cytochrome P450 pathway to morphine 6 glucuronide and morphine 3, which is non-active and which is responsible for the side effect that we have. The excretion is via the kidney, and morphine follows a first order kinetics. Now, for any other drug, especially the strong drugs or strong opioids that we use, the starting point of calculation for you to know the dose that you are going to use for the others is usually morphine. Majority of patients will tolerate it very well, but you'll have about 2% to 3% will have either severe, either mild to or moderate side effects. Now, as we talk about morphine, therefore, remember, you me and everybody has got more morphine in our system than we can naturally take. So a responsible way of giving morphine without severe side effect or without misuse is to start low and build up. And that is what we are going to see in the next few slides. Next. So now we move from morphine, you come to fully synthetic opioid called fentanyl, which today we are going to discuss about fentanyl, which is usually placed on the skin. It's called transdermal patches. We know they are parenteral. We are not going to talk about parenteral. It's usually for chronic pain, for patients who require to be put on opioids. Still broken down in the liver. And on top of that, it has got an oxidase function from the hepatocyte or liver cells, where it is metabolized to its derivative. Where the fentanyl is usually given every 72 hours. But we have had patients who we give the fentanyl patch every 60 hours. So a patient will come and they meet the criteria of being put on fentanyl patch, and when we put them on equianalgesic dose calculated from the morphine they have been on, or an equianalgesic dose of morphine, then you realize that before the next dose in 72 hours, they'll feel pain. So we have about 5% of our patients who are on fentanyl patch every 60 hours. They don't go to 72 hours. However, the commonest is every 72 hours. Don't use it for patients who have acute pain, and don't use it for patients who have not been on opioids, the so-called opioid naive patients. A patient who is opioid naive is a patient who has not been on equianalgesic dose of opioids equal to 60 milligram of morphine in a day or in 24 hours. If you look at the availability of fentanyl in the transdermal patches, you have one that is 12 micrograms. It's given, it's micrograms per hour. You have 25, you have 50, some are available in 75, and then of course we go to 100, 150, and you can always go up and up and up. The point here is don't use it for patients who you have not primed, whose systems, whose receptors are not used to opioids. Start with morphine, and once you start with morphine, then you can always build the patient and sensitize them to opioids, and you can go to fentanyl. From practice, we've seen that patients who've been on 60 milligram of morphine for more than 72 hours, then it will be easy to convert them to fentanyl. Some people will say you need to give the morphine for longer. Some people will say calculate the dose of tramadol if the patient had been on tramadol and convert directly to fentanyl. We've done that for a few patients who have been very sensitive or allergic to morphine, and we usually start on the low dose of the fentanyl, which is usually available at 12 micrograms. Let's remember that the fentanyl is in micrograms per hour. All other drugs are in milligrams. So for us to convert, you have to convert the micrograms per hour into milligrams per day for you to be able to convert to another drug. And we'll discuss this further as we continue on how to convert. Next. Another common one is oxycodone, which is semi-synthetic opioid. We usually have it in our country in extended or slow release. But I believe there's a time we had immediate release oxycodone, which ran out of the market. The difference between extended release or slow release drug and immediate release is the fact that the slow release will take longer in the body. So this is the one that will be given either 12 hourly or it will be given once every 24 hours. The immediate release is less. The difference is not in the amount of the drug in that tablet. The difference is if it is immediately released, then it's broken down immediately and is available to the system. For the slow release, it's usually meshed. In the preservation process, it's meshed so that the release is slow. And that's why it is slow or extended release formulation. It also uses the same system and the cytochrome P450 enzyme metabolism. So you realize that most of the opioids, because of their consistent molecular composition, will go through metabolism via the liver and, of course, hepatocytes, and then be excretion via the kidneys. So what you usually do is before you even start the patient on these drugs, make sure you've done your tests for liver function, for the kidney function. And if these are affected, but you have the opioid available, start them on the lowest dose that you have been on, or you can give. Let's go to the next, because they are interrelated. So how do we dose? We say that morphine is the drug of choice or the referral opioid that we use. So if we understand how we dose morphine, then it will be easy for us to understand on how to dose the other drugs, because we'll be able to calculate the dose of the other drugs based on the current dose of morphine that the patient is using. Let me repeat. More at time, we'll be tempted to say, oh, give this patient 25 micrograms of fentanyl because their pain is severe. Yes, you're right. But how did you objectively do that? How did you objectively determine that you'll go to 25 micrograms? So it's very important to understand at least the dosage or the dosing modality for one of the opioid. And we are going to look at morphine next. So morphine is in a class of drugs that follow what we call first order kinetics. And first order kinetics essentially means, compared to second order kinetics, it means that the half-life of this drug is the time taken for half of the drug that you give the patient to be excreted. I want us to look at this diagram and see that this is a curve. Call it inverted curve, but there's the peak point of this curve. That is what we call the time taken for maximum dose of the serum concentration or plasma concentration for the drug to get to max. After maximum, it starts dropping. But of note is, let's go to the next poll. Of note is the half-life of morphine, especially now we are talking about the morphine in its liquid form, is usually 4 hours. So it means once you give a dose at hour 0, it will take about 4 hours for half of the drug to be excreted. Remember, this is about excretion. But before you go to hour number 4, you realize the curve has a peak. The peak is called Tmax. The Tmax is the time taken for us to go to the to get to the maximum serum concentration that come from that given dose of the drug that you have given. So it's been shown that if you give morphine, especially the liquid formulation, either orally or rectally, then this is the way it will behave. And this will now guide our discussion moving on the dosing. Next. So every 4 hours is when we are dosing, because we are basing that on the Tmax and the half-life. And the half-life is every 4 hours. So notice that we started at hour 0, and then the next hour 0, because it is not going to go to 0 concentration again, it's going to start at a certain level. Call it 0.06 nanograms in the body. The next one is not going to start at 0.06 nanograms. For example, it's going to start at maybe 0.10 nanograms. So there's a build-up from the single initial given dose. And it might take you about 6 doses that for 24 hours for you to have a steady state plasma concentration level for the morphine. And as we do so, it therefore calls upon us to really understand that if you are giving it every 4 hours, if you are to give this patient a breakthrough dose, as we said, then it can always be after the time taken for maximum dosage of the drug, which we said is Tmax, the time to maximum dose. Now, the first curve starts at 0, the second not at 0, the third not at where the second started. So remember, as you give the doses every 4 hours, you are building up on where the other one was. So reassessment of pain after initial assessment is a continuous process. Let's not wait to assess the patient's pain after 24 hours. Because if you are giving this patient, for example, 10 milligram, and you are waiting for 4 hours, then if you wait until the following day, you'll have wasted the whole day where the patient pain might not be well controlled. Paul, we can go to the next. So then what we do, we titrate up the dose. There's a technique that is called the catch-up technique. So here you're catching up with the pain before it gets to severity that the patient cannot tolerate. So what we do is there are several ways of looking at it, but I'm going to show you one of the ways that I do use. So next. So if I start my patient on a dose every 10 milligram every 4 hours, because they are, for example, their kidneys and their liver are good, then the way we calculate the breakthrough dose of the pain drug is 10% of the total 24 hours dose. So if I start my patient at 10 milligram every 4 hours, then the 10% of the 10 milligram given every 4 hours for 24 hours is 10% of 60 milligram, which is 6 milligram. So my starting point is usually 10 milligram every 4 hours and 6 milligram for breakthrough pain. But since the measurement that we use for the liquid is usually a syringe, which can either measure 0.5 mils, 1 mil, 1.5, then we reduce that and we go to 5 milligram. Remember, here we are talking about the 10 milligram per mil dilution for the morphine that we usually use in our country. Next. So assume our patient has got pain at 10 a.m. So I'll give 10 milligram at 10 a.m. So the next dose of 10 milligram will be, we calculate 4 hours, which is 11, 12, 1, 2. So at 2 p.m., I'm supposed to give this patient 10 milligram. But notice that my patient, the regular doses for the morphine of 10 milligram, they're not controlling pain. And the T max for morphine given orally is usually 1 hour. So it takes 1 hour for the drug to build up to the maximum dose in the serum or serum concentration from a given dose takes 1 hour. So if my patient complains of pain at 10:30, I won't do any intervention because the dose I gave is still building up in the system. But at 1100 hours or 11 a.m., if the patient complains of pain, then I have a duty, which is ethical, for me to give them a breakthrough dose for pain. So at 11, I'll give them 10% of the 20. Let's go back. I'll give them 10% of the total 24 hours dose, which is 10% of 60 milligram, which is about 6 milligram. And it will go on and on. So when it comes to the next regular dose, it won't be 10 milligram. It will be 10 milligram plus one equal dose of breakthrough amount of the drug that we usually give. So the new dose for this patient now will be 10 milligram plus 6, which is 16 milligram every 4 hours. So that is at 2 p.m. Then we wait for the next one. From 2 p.m. we have 3, 4, 5, 6. At 1800 hours, which is 6 p.m., if the patient pain is well controlled, we continue with 16. If the patient pain is not well controlled, then in between, we have breakthrough doses, which are now 10% of the new 24-hour doses. And since the new one is 16 milligram, if you have to give every 4 hours, it will be 96 milligrams. So the new breakthrough dose will be 9.6, and you can say it is 10 milligram. You realize that no two patients will behave the same if you use this model. But 60 to 70% of our patients will respond to this 10 milligram every 4 hours. Because as we said, remember, this is coming to supplement the endorphins that we have. But if the patient continue being in pain, then you give the breakthrough dose. The mistake we make is that without using a system, without using a given way of doing things, then we might find ourselves either dosing the patient or overdosing the patient on the opioids, causing very severe side effects. But using a well laid out, studied model of escalating the opioid doses, then it assists us to manage our patients' pain well, using opioids in a safe, yet effective and efficient way. Next. So for us to do this, we must always have a pain diary. And I should tell my colleagues that unless you've indicated or noted or documented that the pain was 8 out of 10 or 4 out of 10, and at that time you started the dose at 10 milligram, I won't be able to know. I won't be able to know. We might all agree that it is 10 milligram, but maybe the patient came to us yesterday, and by now the patient is on 20 milligram of morphine. So pain diary is extremely important. And this diary can be used in hospital and also out of the hospital. And as you continue adding the doses, please indicate. So for those of you who use electronic health records, we use it in Aga Khan, we use EHR. One of the drugs that auto-stops itself in 24 hours is morphine and other opioids. And the reason why this is so is because you need to review at least once per day. But more at time, I have found it useful to see this patient. If they are within the hospital, they are admitted, you're able to see them at least twice per day and inquire from them about their pain. Next. So before we go to the next discussion about the side effects, realize that we have not looked at any calculator that you can use to calculate the equianalgesic dose of what you can use. Calculators are there, you can use, they are available, but make sure that you use a calculator that you've agreed with your team that this is what you can use to convert maybe fentanyl to morphine, morphine to fentanyl, injectable morphine uh, to oral. And as we do so, realize that some will cause severe side effects, other routes will cause less side effects. And the side effects are global and can affect any of the systems. But most of the side effects, whether it is about a side effect in the GI, in the central nervous system, in the urinary system, will go away, except the side effect of constipation, which, because of the way it's mediated, must always be taken care of. So constipation, when you give the opioids, whether morphine or any other of the opioids, it's good to always make sure that you give a laxative. So what are the side effects? We've said people will feel sleepy, others will feel nausea, vomiting, constipation, and constipation must always be taken care of. In the central nervous system, they might feel dizzy. Sleep, of course, increases, but most of these side effects do go away. They might feel heaviness of the head and all that. In the urinary system, some will talk about urinary retention, that is a one-off. However, let's repeat, you give any patient opioid, always make sure you give a laxative, because the side effect of constipation is mediated through the nervous system in the GIT. It's called gastric plexus. It's not through the central nervous system. It's through the GIT. So as we continue, let's differentiate between these terms. Yes, we can have side effects, and we mentioned them, but then there are terms we use interchangeably, but they don't mean the same. We use tolerance, we use addiction, we use dependence, we use pseudo addiction. Those are not side effects. Those are the behaviors of a patient who's been on these drugs. One of the differences, so that we don't use these terms interchangeably, is for us to really understand what it means. Addiction, essentially, will mean that this person has got a compulsive, harmful use of this substance, of the opioids. Compulsive. They want to use it. It's harming them. So you look forward to having it. You feel good when you have it. But essentially, you might not need it. So that's addiction. But dependence is when the body itself physiologically cannot function without that substance. Cannot function without the substance. So dependence, therefore, means that the body is missing the drug, the body is missing the opioid, the body is missing the substance, and therefore for you to say that this person is dependent on that molecule of or opioid, then they must have withdrawal effect. Those who look forward to using the drug in a compulsive way and they know it is harming them, they don't need it, that is addiction. Dependence, there must be some element of withdrawal symptoms. Now, these are usually confused with tolerance. And as we give our patients more and more opioid, day in, day out, giving them opioids, then their systems, maybe in the cell, at the cell level, maybe at the receptor level, maybe at where the signals are produced for response to be, get used to the opioid. Get used to the opioid. So you find yourself using more of the drug to treat a certain amount or level of pain. So you start a patient at 10 milligram every 4 hours, they come to you after a month, it's not now working. It doesn't mean that the pain is getting worse or the disease is becoming more, because these are the terms we say, and the patient will ask you genuinely, is my disease getting worse now that this drug that you gave me, 10 milligram every 4 hours of morphine, is not working? This is at a point where we call tolerance. Educate the patient that this is a normal way of responding to some of these drugs, because the body itself have got this drug itself. Whatever we gave was just a supplement. So at the point where the neurotransmitters, the receptors are used, or the signaling aspect, they get used to the drug. The only thing we need to do is increase the dose. It doesn't mean the disease is becoming worse. It doesn't mean that the symptom is becoming severe. It just means that this is a complex situation that patient will suffer from when they use some of these drugs. And you realize that if the patient was on maybe 10 milligram of morphine every 4 hours, if you increase even to about 12 or so, then it's able to take care of the pain itself. That is tolerance. Differentiated from pseudo addiction. Pseudo addiction, as pseudo says, is a false addiction. We say that patients have got drug seeking behavior. But then these are the patients with the true legitimate pain that you've been controlling. And the reason that this is so common and we don't diagnose it is because we underdose our patient. We inadequately dose our patient. So they say, yes, you gave me 10 milligram of morphine, it took care of my pain, but before the next dose, the pain came back. But immediately I took, then the pain went, but came back before the next dose, but within an hour or within an hour. So it means the T max, the time to maximum, is still the same, but the serum level to control the patient pain is on a lower level. And this is the main reason why most of our patients experience undertreated and relieved pain, especially when we use opioids, because we don't want to go higher because we're fearing addiction. We don't want to escalate because people believe that there's no other drug that can be used apart from what we are using. So we would rather go for a lower dose, have the patient in pain, but then have a space of always increasing. The danger of that is the patient will have pseudo addiction. And as we said, pseudo addiction, other treatment will make this patient have negative thoughts, suffer, and get to what we call pain behavior. And is it by their choice? No, it's not by their choice. It's because we are not dosing them appropriately. We are giving them a very low dose of the drug, which is taking care of the pain initially, then the pain comes. And then when that does not happen and you're telling them you cannot add them more painkillers or add the dose, then they go do what we call doctor shopping. They jump from one chemist to another, one pharmacy to another, one doctor to another, and they say the patient has got pain behavior. Patients don't cause pseudo addiction. We do cause pseudo addiction to our patients. So next, Paul. So let's look at this case. And I thought about looking at this 66-year-old CF who was admitted with severe back pain with cancer of the cervix, which was stage 4. This pain was constant for 2 months. No improvement despite medication. She described that her lower back pain was 10 out of 10, but felt like electricity. And it shoot down her right buttock. She also had the experience of lower abdominal pain, which she scored at 8 out of 10. When you saw the patient, of course, with these two pains, which is 10 out of 10 at the lower back, 8 out of 10 at lower abdominal pain, then the patient was tearful, was depressed, and reported that she was constipated. The patient was on diclofenac potassium, 100 milligram once per day. The patient was on dihydrocodeine, DF118 at 60 milligram twice per day, and was also on beta pain, 2 tablets 3 times in a day. So next, do you see any problem with this prescription? And what changes can you effect to this medication for this patient? I think ASAP, let's see what people will say about this. Maybe, Paul, you can put back the case and see what suggestion would come from people about what is happening in the management of this patient's pain. Is there any problem to this prescription, and what can you do about it to effectively and efficiently manage this patient's pain based on our discussion in the last 1 hour?
Feel free to put your suggestion on the Q&A or the chat. You can also raise your hand, and Paul will unmute you and give you an opportunity to respond. Any suggestion? So I can see, Prof, from one of the attendees, that is Kate, says no laxative has been prescribed.
Okay, thank you. That's great.
Emmanuel says diclofenac other dose.
Okay.
Lydia Roy says patient is on 2 mild opioids and without a laxative.
Okay.
Paul says DF118 should be 8 hourly, and laxative, no meds for neuropathic pain.
Okay.
Then somebody also, Lafayette has said BD and TID issues. Teresa has mentioned, saying the prescription is not as per the WHO analgesic ladder. She has severe pain, but on mild opioids.
Okay.
Petra says, yes, there's a problem with prescription. There is a combination of the opioids without laxative.
Okay.
Anyone else suggestion in terms of Teresa has also added she has shooting pain with no, which is neuropathic with no adjuvant. Do you have any other?
I saw a had come up. I don't know. Sometime.
Anyone would want to speak? We can unmute. Please raise your hand.
Okay, my suggestion is not far
Yes, go
from.
ahead.
My suggestion is not far from whatever that you've read. Looking at the case and looking at the combination of the drugs that this patient has been put on, I think the problem where it is the prescriber gave 2 codeines. Petapine is a codeine and the TF118 is a codeine. That is number 1. And that is a burden, I think, to these clients. We need to give 1 codeine. And again, looking at the scale of the pain of this client, which is at 8 over 10, meaning these drugs are not assisting. This the clinician could have scaled up and leave alone giving out the DFs and the betadine and go straight and give these clients morphine, which I think could have assisted better than whatever that we are seeing here, and then incorporate in a laxative, because already the client is depressed and tearful because of the constipation. And again, looking at diclofenac potassium, now this again disorganizes the whole thing, because this is an NSAID with the 2 opioids, which is not addressing the client's problem. According to the presenter, we've seen that severe pain, we are going up. We go straight to morphine, and then we give an adjuvant. At this particular time, either we can give any adjuvant that the clinician could have opted for, and leave out this prescription. It is not assisting this case that we are tackling here, the scenario that we have here. Thank you.
Thank you, Rose. I'll also give the floor to Lynette John. Lynette, go ahead.
Thank you so much for the opportunity. I'm looking at this medication critically, and going by the score of the pain, the treatment is under treatment, because the score of the pain should be at the severe pain. So we should give treatment for severe pain management. But apparently the prescription is focused on the moderate pain management. Then number 2, always we are told that the hand which prescribes any opioid, we have to consider the constipation part of it. So laxative needed to be given. And then the third one is the treatment is under dosage. If you look at the word is going away, but all the same, it is not the correct treatment for this severe pain management. Thank you.
Okay.
Thank you, Lynette, for that input. Lydia Arue. Lydia, your hand is up.
Okay, for me, I think there is everything wrong with this prescription. We have 2 drugs in step 2. And despite having the 2 drugs from step 2, the patient is still in pain at a score of 8 over 10. So I would do a fresh prescription and probably put her on morphine because of the severe pain, and also put her on laxative because of the constipation. And is also a patient who would benefit from an adjuvant, probably Tegretol due to the neuropathic pain. Instead of diclofenac, I would maybe consider maybe paracetamol or brufen. Yes, thank you.
Okay.
Thank you,
Thank
Lydia,
you.
for that input. Rob, I think the other comments mostly have the same, almost the same suggestions, but also there's 2 of our colleagues who have also mentioned that we also need to look at the psychological aspect of the pain that hasn't been addressed. And also somebody has also mentioned that we also need to consider non-pharmacological management of pain, and also look at including adjuvant medication for neuropathic type of pain.
Okay. Thank you. Yeah, and the people who've spoken are right. Now, I believe this kind of patients will see day in, day out. With all the issues that have been raised, 2 months with constant severe pain at 10 out of 10 actually tells us that we failed as clinicians. We should actually consider scaling up one of the opioids or stopping these two. These two are weak opioids, and they contain the same weak opioid. DF-118 has got codeine, Betapin has got codeine. So essentially, we are overdosing this patient on codeine without going up or escalating the drug. So we should consider either going to the max of DF-118 or going to a stronger pain medication. The same thing about diclofenac, we can go up. This patient is depressed, and they have some element of neuropathic pain. Adjuvant drugs should be used for them. They don't have a laxative. That's why they feel constipated. Psychosocial support or psychological support is very, very important. Patient education should be the starting point. So all those 7 points which have been said are important. The ODBD TID, I'm happy that it was picked because we should be able, maybe this patient was told to take DF-118 BD, and they were taking in the morning and at lunchtime. And then they were told to take Betapin, TDS, and they were taking maybe in between the two doses of DF-118, and then at night, all those things will have to be considered. And also the use of course, adjuvant medications. Next. So we've seen this. Next. So we are seeing neuropathic and nociceptive, and the changes include diclofenac. Yeah, all those, these ones we have said. Now, this we cannot complete our discussion today without talking about the opioid epidemic, which is something that is happening. And we might think that it is happening in the Western world, it is not happening to us. It doesn't have to get to billions or millions of people. You just need to see 2, 3 people who are misusing these drugs and know that we have started experiencing opioid crisis. And remember, it will become a national crisis. People and families and communities will be affected, and actually it will lead to death. So the question I thought we ask ourselves today, as people who are proponents or supporters of use of opioids, what do we need to do? How can we make sure that we mitigate or tackle the opioid epidemic that might come to us? So beyond asking for supply, what else can we do? Because I can tell you for sure, overdose, addiction, and misuse and diversion will come our way. And these figures and these are coming from the US. And you can see that 70,630 people died from drug overdose, opioid, in 2019. And when a drug becomes misused by 10.1 million people in a country for 1 year, then that is a national crisis. So for me, what we need to do to avoid having this situation is to make sure that we educate our colleagues, educate our doctors, our nurses, our clinical officers, our pharmacists, then that let opioids be prescription-only medicine. Let's take good history of the patients who are coming to us for opioids. Have they used it before? Who prescribed? And even us as prescribers in our hospitals, in our hospices, in our palliative care unit, let's make sure that our assessment is based on scientific ways of doing it. We do escalation as per the given rules, and we don't just base it on a subjective thinking. How do we convert this patient from 10 milligram of morphine to 15 and escalation? What history do we take in between? And most importantly, as we continue using them, let's do a reassessment. The assessment to me will tell me this patient is either overusing the drug, there's drug diversion in that house, it's being given to someone else, or the patient is tending to becoming either dependent on the medication or there is something else. And lastly, it's about tolerance. Please don't let your people have pseudo addiction because we are underdosing them and the patient says that the drug is not taking care of my pain. So it's a fine balancing act when it comes to utilization of opioid for pain control. Let's go to the last slide. So therefore, our take-home message, if you were to go for some 5 points, be proactive in pain management. Proactiveness means see a patient with non-verbal cues of pain, do multidimensional assessment of pain. I want to close my eyes and close my ears when someone tells me that this patient was in so severe pain, I started them on oxycodone, slow release 20 milligram. That tells me that is a very dangerous practice. How did you assess? How did you come to an objective assessment and decision that this person required 20 milligram? Individualize is not copy and paste. Look at the liver and the kidneys of this patient. If they're not working well, reduce the starting dose. For patient safety, quality, effectiveness, and efficiency, you have to engage the patient through history examination. Don't just become a scribe writing the pain medications. This is still a patient. Ask questions. Take history about the pain, PQRSTU, about the drugs they have used, about how the pain behave, what medications they have used before. Ask a sensitive question. Do you abuse any medications, including abuse of marijuana, because it's been shown to affect the way the body responds to pain medication. Multimodal approach. Start with non-pharmacological ways of pain management. Go to the weak opioids if the patient has got moderate pain. Use adjuvant if the pain descriptors are in keeping with neuropathic element and aspects of pain. Escalate approach, slowly by slowly, individualize to that given patient based on how they report the pain is behaving. Eventually, if you don't have the patient with you, as you take them home with their drugs, they'll go and ask their neighbor or call the doctor Fred and ask, this drug I was given by so and so, is it good for my pain? That tells us we do not educate the patient, we do not engage the patient. And I want to stop at that point, Dr. Kenyajui, and back to you. Thank you for listening up.
Thank you so much, Prof, for taking us through this wonderful presentation. We have a few questions, and I'll start with a question from Ibrahim. He had asked, what if a patient takes less morphine, let's say less than 60 milligrams in 24 hours? Will it still work in terms of adequate pain control?
Yes, and that's a very good question, Ibrahim. Some patients will take less of morphine than others, and that's why you have to reassess. The maximum amount of time you should take to reassess the patient should be 24 hours. So some will start at 10 milligram every 4 hours, then you can come down to 10 milligram every 6 hours. If the patient says the pain is very well controlled, or they suffer from very severe pain or severe side effect. So yes, patient can still be on less. When it comes to conversion to fentanyl, we say equianalgesic dose of 60 milligram. For some patients, by the time you are getting to 60, they have severe side effect from morphine that you want to convert them. Maybe you have fentanyl and you can start at the lowest dose. Because this patient now, after being on even that low dose of morphine, they are taken to be opioid sensitive. They are not opioid naive.
Thank you, Prof. We also have a question from Kamau. She's saying, good presentation. My question is, what about a patient who will have a breakthrough morphine only once in 4-hour cycle? Let's assume after the first hour or on the third hour, what would be the dosage for the next cycle? So maybe, Prof, if you could maybe just briefly maybe do a repeat of the titration and the rationale.
Okay. If a patient has been on 10 milligram, and let's say we started our patient at 10 milligram, on 10 milligram at 2 p.m. The next will be 3, 4, 5, 6 p.m. And the patient does not suffer pain until about 5 p.m. This patient still requires a breakthrough dose of morphine, which could be 5 or 6 milligrams based on how your syringe can measure. The next new dose that will be regular for this patient will be 10 plus 5, which should be 15. If you've given the patient at least one breakthrough dose for their pain and it controls the pain, it means that the initial regular dose for the pain is lower than the patient requires to have a steady state plasma level of the opioid. So the new dose will be 15 if you give any breakthrough. So it doesn't matter how many breakthrough doses you give. Whether it is 1 or 4 in between the two doses, the new dose should always be plus 1 equianalgesic dose of the breakthrough amount that was given.
Yeah, thank you, Prof, for that. The other question is from Caroline. She's asking how to manage uncontrolled pain at end of life.
Oh, a tricky question because it depends on why is this pain uncontrolled. Is it because we are not using opioid to the maximum? Is it because the patient is not tolerating, either because the GI is not working or they are getting very severe side effects? Have we gotten to marks of combination, looking at all the routes of pain, causation, neuropathic and nociceptive? So if you have used the maximum and the pain is still refractory and it is end of life, these are some of the patients who we recommend for what we call palliative sedation. And palliative sedation does take care of pain and all the other symptoms, and their modalities, routes, systems, protocols, and policies on how to undertake palliative sedation for some of these patients. For some patients, we've been able to give them morphine, and when you give them the oral, they are not able to tolerate. When you give them parenteral, then they are able to tolerate. And the best parenteral route to give morphine will be subcutaneous. It gets to a point where you realize these patients are also not able to maintain even the subcutaneous line, and also they are getting hematomas. Some of these patients, we do convert their drugs to continuous infusion of morphine, calculated from IM or from oral to the continuous infusion. So those are the two ways. Either you palliatively sedate the patient or give a continuous infusion, but make sure they meet the following criteria. Their pain is refractory to what you can give maximally and based on multidimensional assessment of how the pain is for this patient.
Thank you, Prof. And maybe just to also add a question on management of pain at end of life. Recently, I was called by a family to review their loved one who was at end of life. This patient actually was opioid naive, but when I found out she was in very severe pain, and not even able to take orally, or from the history they got, they gave is the patient was also had very severe vomiting. So oral route was not sort of like the recommended route of administration. This patient was also being cared for at home and bedridden. Subcute was not a very feasible option, and especially during the period of the consult, because actually I reviewed this patient at almost at night. In those situations, what other alternatives would you recommend? IV, morphine, and especially where even you're not even having access to like the syringes that can be able to administer and titrate dosage in a continuous way. What would be your advice?
Thank you. Thank you, Dr. Kenyajui, for that. You realize that for this patient, the bioavailability of most of the pain medications are affected. Even the oral morphine itself, the system, patient is bedridden, not active, maybe not feeding well, cannot tolerate orally, the oral bioavailability is affected. So we have to ethically approach this question. What is our main aim? What is our main goal? It is to control this patient's pain. Some of them won't have access IV. So these are the patients we say our main aim as clinicians is to control their pain. This patient is at end of life. They are writhing and groaning in pain. We will have failed our ethical duty if we don't control their pain. So this is a patient I'll go for IM. This is a patient I'll go for even sub-Q, calculate the lowest dose, and if it is we are able to have the patient at least be comfortable, we can always escalate the dose. But IM, IV, sub-Q for this patient is always an option that we can always give. Sometimes, even as we do so, we've been able to even give the patient some drops of the oral morphine, and we tell them, or we keep it in the mouth, because morphine absorption starts in the mouth. But all these routes should be used. As long as your aim is met to control the patient's pain, whatever route that you are going to use for pain control.
Thank you, Prof. Maybe for the next 1 minute, if there's anyone with a burning question, please raise your hand. We'll give you a chance to ask your question before we wrap up the session. Anyone would like to ask a question? Prof, I can't see anyone who has raised their hand, so I assume everyone is comfortable. I can see very encouraging comments from our audience and from different parts of the continent. Even we have people from even Ethiopia who have appreciated the presentation. So with that, I think that will bring us to the end of the presentation. I hope based on these conversations now, we'll be able to effectively assess our patients, classify their pain, and manage their pain holistically using both non-pharmacological and pharmacological interventions. And we also remember that we need to titrate the opioid dosages as we monitor the patients, and regular monitoring, regular communication with the patient and their family is crucial. Also, we remember to include the laxative as we give opioids, just to avoid the constipation and other side effects. And I think the other bit is also to make sure that we are good stewards of opioid, to ensure that we don't end up with opioid crisis in our country. With that, I would want to thank everyone for creating time to join us. I'll hand over the floor to Emily, just maybe to give any feedback from Kehpca, and whether others will just guide us whether they will be able to get CPD points for this attendance. Emily, over to you.
Thank you, Prof, for the great presentation, and thank you, our chair, Dr. Asaf, and I'll hand it over to our ED to give the final remarks. Thank you.
Thank you so much, Emily, and special thanks to Prof. Weru for a great and insightful presentation. Dr. Kinyanjui, we truly appreciate your moderation, and everybody who came, we are grateful. Let's continue learning. Just a quick announcement that we have and are preparing for our 7th National Palliative Care Conference. It's happening in Mombasa on the 25th to the 27th of February next year. And therefore, karibuni, welcome all. We just made the announcement today, and we look forward to hosting you. Thank you. Have a nice time. The other webinars will be announced as they come. Good night.
Thank you.
Thank you, everyone. Have a lovely evening. Bye-bye.
Bye-bye. Good night, everybody. Blessed night.